Hello, welcome back to the Neurocritical Care Society podcast masterclass series. This is your host, John Rosenberg, along with Dr. Stefan Mayer. We are here with a very special guest, my former senior resident, Dr. Jamie Odell. Dr. Odell is assistant professor of neurocritical care and emergency medicine at University of Maryland School of Medicine. And we look forward to talking to her today about a topic we all know and love in one of our areas of research, paroxysmal sympathetic hyperactivity. And before we begin, just want to say that the views expressed on the NCS podcast are solely those of the host and guests, do not necessarily reflect the opinions or official positions of the Neurocritical Care Society.
All right. So thanks everybody for coming in to listen in on this chat. As you know, John and I both work together at Westchester Medical Center in lovely Westchester County, New York, just miles north of the city. So Jamie, I've met you. I think that we met at the Houston, Texas Neurocritical Care Research meeting, and I remember your talk very well. And so I guess my opening question for you is, how did you get interested in this topic? Because it's so ubiquitous, so poorly understood, and really understudied.
Yeah, so it's kind of a roundabout way to some degree, but things all just kind of fell into place. I think so. I came into neurocritical care as a fellow at Maryland in 2018, not really knowing exactly what I wanted to do. I thought I was interested in TBI in part because I have this more of like a cognitive neuroscience background, and I like the idea of all the kind of, in TBI, you manage all of these acute issues that are very rewarding for the intensivist at bedside, but then there are all of these longer term consequences or issues like coma and then other things, implications for cognitive and emotional functioning down the road. So TBI was an interest of mine, but I kind of didn't know exactly what in TBI I wanted to do. I thought maybe coma. And then Dr. Neeraj Bajadia, who's been my mentor in a lot of this work, pulled me into his office and was like, hey, I've got a project. I was wondering if you might be interested in this. And it was an IRB that they had just written on dysautonomia and TBI. And so it seemed interesting. I wasn't 100% convinced that that's what I wanted to do, though, until I really started digging into it. And also until I really started taking care of these patients in the ICU. So I think then, two things really got me hooked. One was at bedside taking care of these patients. It's called storming for a reason. It's very dramatic and can be hard to manage. And I think there's just not that much evidence out there for what to do, for why it's happening. And it seems like, there's a real void there and a need to study it more systematically. And then from a kind of more research and intellectual perspective, once I started kind of conceptualizing it cognitively the way I have other things in the past, it's so interesting to me, the idea that this is this almost like a release phenomenon where you have this release of fight or flight activity that some kind of stimulation just causes your brain to go into this recurrent fight or flight state that you're not really able to turn off. And there's a lot of overlap between PSH and agitation and pain and what is it? It's hard to know when you're treating it. And I think there is a lot of overlap because that's, that those are similar pathways that are being activated. But so I think when I conceptualize it as that, and you imagine what would the experience be like? A lot of these patients are obviously comatose, but if you can imagine them emerging from coma and having this constant feeling of their heart racing, their blood pressure going up, and not really knowing why, not knowing how to control it, I think to me that also then can connect to how some of these patients can have longer term cognitive emotional issues, and even this potential connection to PTSD I could see as being there. And so I think of it really as a neural network problem, and that's what's gotten me really interested in trying to understand the neuropathophysiology of that through neuroimaging. And then so once I kind of started getting into it, I started realizing again that there's kind of a real void there and a lot of research that's being done too. So it was a good opening to be able to feel like I could really potentially make a difference in studying this in depth.
Interesting. John, by all means, chime in, but I love this stuff. So I'm really curious. Got a bunch of questions. What do we know about the neuroanatomy of what sets this off? Because some of your severe strokes, they get real bad and some don't. Your TBIs, same thing. And then tied into that is, why is it so much more common and more intense in the younger male TBI population than, let's just say, in your 60-year-old thalamic hemorrhage guy, with some IVH or something? Do you have any thoughts about that?
Yeah, I don't know. I have speculations, and I do think the age part is very interesting. Also, because if you look at the pediatric literature, it's more common in older kids. So it's like this like late adolescence and like early adulthood and the male issue. So I think there's something neurodevelopmentally, maybe about like myelination of frontal lobes or something that may play a role. And then the male predominance, I also don't really know whether there could be some kind of neurohormonal involvement, or like, is it related to like muscle mass that they're like able to just like mount this, like, the muscle motor activity causes them to be more febrile and things like that. We don't really have a good sense, but those are definitely like the two things that show up, at least the demographic kind of features that show up over and over again, is age and sex. But then in terms of neuroanatomy, I think it's also there are different kinds of lesions all over the brain have been associated with it, like in case reports and things. I think the initial Penfield described this like diencephalic autonomic epilepsy is what we kind of think of
Yeah.
storming. So there's this at least initial idea that it's something deep in the brain with the diencephalus. But I think more recently, at least most of my research has focused on PSH and TBI. And the biggest association that we find is with diffuse axonal injury.
Yeah.
So like the white matter shearing injury. But I think also what we're starting to find is more like the frontal injury, frontotemporal contusions as well. And so again, it kind of to me comes back to, I think there may be some, at least in these TBI patients, kind of a like frontolimbic disconnection that is happening. So you're losing this kind of frontal control of the limbic and autonomic centers. And I think the DAI, it's diffuse white matter disconnection. And I think that this is like a neural network problem.
Yeah.
Yeah, you're right. You can see it in stroke and ICH, and I feel like we see at least some form of dysautonomia, whether it's really PSH or not, or more just central fevers with IVH a lot more than anything else. So that blood near the hypothalamus, but it's not just hypothalamic injury by itself that causes this. There's something else. I think it's kind of a bigger functional network problem that I think we haven't even really been able to get at yet.
Yeah. Well, I was going to bring up the DAI thing because that's been my distinct clinical impression.
Yeah.
So DAI cases with all the hallmark kind of pattern of sharing injuries on the MRI,
Yeah.
like that. So I'm going to tell you about some of my weirdnesses, but I think first, why don't you tell our listeners about your research?
Yeah. So the research that I've been doing, I think there are a couple of different aspects of it. One is trying to be able to better quantify PSH. So in 2014, there was this study put out in Journal of Neurotrauma. There was an expert consensus definition and diagnosis criteria. There was the PSH-AM that I think is something that we've started to kind of implement clinically in our EHR, even to try to evaluate the severity of PSH. And so I think that effort was really helpful in being able to start to like potentially quantify and standardize the diagnosis of PSH, but it still like leaves a lot to be desired. It's very subjective and still very much like a diagnosis of exclusion when you're approaching these patients. And even that, it can be, I think patients can have really bad storming at the same time that they are infected. Like the two things can happen at the same time. They're not mutually exclusive. And oftentimes we're starting treatments later than maybe we could if we were able to recognize it based on a more objective criteria. So I think that there should be a physiologic signal there that we should be able to detect. And that's part of my interest too, was working here with Dr. Bajadia, and then Dr. Peter Hugh does a lot of physiologic data analysis and big data work. And we've been trying to develop some sort of way to find a kind of automated quantitative signal of storming, whether it's PSH or different forms of dysautonomia, to really kind of like phenotype it quantitatively. And my dream would be to have something on the monitor that can show up like that assesses the past 6 hours and gives you like an index of your like PSH index,
Yeah, I love it.
PRX or something.
Yeah,
Like,
yeah,
you know?
absolutely.
Yeah.
Now it's funny because I mean, one thing for our listeners is this entity's what's really hysterical about it is just like neurogenic stun myocardium, this entity has like 17 different names that are
Yeah.
identified, right?
Yeah.
PAID and
Yeah.
just diencephalic seizures, which are
Right.
not seizures, I don't think.
Yeah.
Just crazy stuff like that. Do we really understand the landscape though of dysautonomia in general? Is it all paroxysmal, sympathetic, and how does that? We get the central fever thing and all that. I mean, it doesn't seem like we have a good nosology or classification.
Yeah, I think that's absolutely correct, and honestly, I feel like that's one of the issues that I have with the PSHAM is that it almost confuses the picture more because if you go through and tabulate, like you get a clinical feature severity score and then the diagnosis likelihood from it, you can get a high score without symptoms even being paroxysmal, and so it really is kind of like a different there are multiple different phenotypes that this can score you for, and that doesn't really distinguish what's going on. And my sense is that there probably are different, like, underlying brain injury patterns that cause these different phenotypes that we haven't really hammered out. Again, because like there's the central kind of persistent central fevers, and there can be people who have more like persistent tachycardia and tachypnea.
Right.
I still don't understand the like central tachypnea is something that has not been well described either. I think. But then I think there is a phenotype that's much more classic paroxysmal sympathetic hyperactivity that really comes and goes. And I think that is much more a neural network problem. But yeah, I think that we need better kind of phenotyping of the actual physiology to then figure out specific treatments and what kind of like pathology it is caused by.
So one of my weirdnesses is I love to go to the bedside, and before I even touch the patient, I go to that view where you get the 24-hour
Yeah. Mhm.
right graphic
Yeah.
your vitals that go
Yeah.
into the bedside monitor, and I've come up with something called picket fence sign.
Uh-huh.
If you can imagine, you look at the heart rate and blood pressure, particularly in an unsedated state, and it's like every 10 minutes or 20 minutes, it's like boom, boom.
Yeah.
It's like spiking my finger up if you're just listening to the cast. Do you just and I got interested in that, just working with multimodality monitoring
Uh-huh.
years ago. And I still, even if we don't have a multimodality monitor in yet, I still like to look at this battle signs graphically. Have you
Yeah.
picked up on that, or
Yeah, that's
you know,
honestly, that's what I like to do too. If when I'm rounding, people say there's concern for storming, that's the first thing I'll do is I'll look at that vital sign monitor and look for those blips. And
blood pressure?
yeah, and then you're trying to
Quite
see if
correct.
they're like how long they last and how high they're going. And yeah, I think that is kind of the classic phenotype of PSH.
And the periodicity is really fascinating too. I mean,
Yeah.
it's not precisely every 10 minutes, but it's like every 10 minutes.
Mm. Yeah.
So it's almost like there's some kind of wheel in there
Yeah. Yeah, and that's
kind of
interesting.
spinning and suppressing and releasing and suppressing and releasing.
Right. Yeah. And it's interesting that you mentioned that because we've done a lot of different ways where we've tried to like visualize the vital signs. And we've done things like power spectral analyses. And we have seen that there's this, it was kind of like a lower frequency, like a Q8 hour kind of increased power band in some of these storming patients. But it's like very hard to figure out how to analyze all of this stuff. But there definitely is something to that periodicity. But I think the other big part of it is that like, these patients are, like, extraordinarily sensitive to any kind of stimulation too, and, I think people will say, "Well, like, it's happening every hour, it's probably because 'cause they're being examined every hour," but I think that's not to say that it's not storming, I think they're still having, like, an outsized reaction to the non-noxious stimuli, it still may be worth, addressing.
Yeah. John, you have a question for Jamie?
Sure. No, this was great. I guess I'll start with an anecdote and ask a question. I remember when I don't know if Jamie remembers, but so Jamie was my senior resident there when I was at Penn, and I think you like found out I was interested in neurocritical care. We were chatting. I think you were like about to get on your bicycle. I think I told you, and you're like, oh, like, and I think you still had your bike helmet on. You proceed to like walk me home with like your bicycle out, like just talking about like your experience from neurocritical care and like the whole fellowship application. I thought that was very nice of you.
This was a common thing that I used to do, is forget to take my bike helmet off.
Few people on this, yeah, exactly. I was gonna say a few people in this podcast will get that reference. But
Yeah.
I'm just curious to tell us, since you started, we all learn about storming as a neurointensivist, but since your research, tell us some of the key things that you learned, or some of the things that were new to you, or kind of helped you in your clinical practice.
Yeah, I think the biggest thing, honestly, I think when we first started out, like storming is new, and so then we're like, oh, this is storming, this is great. But then I think the thing most recently that has struck me is that you got to keep looking for other things that are causing the storming, especially like if it's getting worse or if it's not responding to treatments. Because I think that's the biggest danger that I see, is like the anchoring bias onto storming, because your medications and things that you have to treat storming, they're going to suppress the symptoms. But if somebody is septic, you're not going to be able to fix that with like bromocriptine, right? So I think, and it doesn't mean that you can't co-treat, but I think always reassessing and reevaluating for something else that could be contributing. Because I'll tell you, I think some of the worst storming cases I've seen, like, I think I remember having a patient who he had DAI, he had all the things to have storming. But one day he was storming so much and he had EEG on, so we knew it wasn't seizure, but we actually had to paralyze him to get his respiratory rate down.
Wow.
He was bacteremic at that moment. And I think I've seen that kind of thing several times now. And so I think always remaining like humble about your differential diagnosis, especially if things are worsening while you're still escalating treatments, to always kind of come back to look for other things.
Yeah.
I think just today, we found somebody who had like a pulmonary abscess that was triggering the storming. So it's extremely common that things like that will come up.
So let's talk about treatment. And I want to kind of set the stage, because the first line is really just to.
Throw in one more question before treatment.
Oh, yeah, sure.
I'm curious about the different phenotypes. I know we spoke about. Tell us a little bit about, and maybe Stefan, you can chime in as well. Different phenotypes you see as storming that we should be aware of.
Well, I think so. One thing is, I think that it does present in kind of a predictable manner, at least post TBI. I think post some other injuries it can be different, but like, the initial phase, you may not recognize it. And I think that's in part because patients are sedated, but also if it is a neural network problem, there's probably some sort of like maladaptive plasticity that has to happen over time for it to really take hold. But then typically it presents around the end of the first week of injury, and then is can be very severe for the next like week or so. A big proportion of those patients will end up kind of improving and not necessarily having long-term storming. But then like a subset will have that kind of classic. They can develop storming much later down the road for any little thing. I think the other like phenotypes that like we would categorize as dysautonomia, but it might not necessarily fit as PSH, would be just these patients who are like persistently febrile, or the like, persistent tachypnea. And then there's also like the things that you could think of as like a hyperadrenergic crisis just at injury onset. And we think of that a lot more obviously with like aneurysmal subarachnoid hemorrhage, but you can see it in severe TBI too. And that can be associated with like the stunned myocardium and coagulopathy and other issues. And, elevated catecholamines on emission, and it's usually associated with more severe injuries. And the relationship between that and whether somebody develops PSH down the road hasn't really fully been elucidated either. Those are kind of two separate entities, but both we think are probably bad. But yeah, I don't know if Stefan, you have other thoughts. You have probably more experience seeing all of this stuff than I do.
No, actually, I that's why I think we're asking this question. I don't really have a firm classification system in my mind, and I think it's almost like a grab bag.
Yeah.
You got a lot of different Halloween candy. You stick your hand in blood and pull it out, and you get various different mixtures
Yeah.
of combinations of symptoms.
Yeah, and I think that gets to treatment and, like, figuring out, like, what is important to treat, what is bad for the brain, what can we tolerate, and I think that, that is also a big challenge, I think.
Let's talk about treatment. We got a few minutes left. What's your approach? How do you do it?
Yeah, I usually will start with propranolol and bromocriptine. They're my go-tos, and usually PRN morphine, and usually we're at that point the patient's probably on propofol or something, and we're usually trying to switch them to Precedex to be able to wake them up. But then I recently, if they're not on Precedex, I'm hesitant to put them on it because then we get into what I call the Precedex jail, where it can be hard to get them off of it. But Precedex is quite effective, I think, for PSH. But to get them off of it, we'll often use clonidine and things like that. I think I'll use like a tiered approach to add on additional medications if needed. But a lot of those medications have side effects, so it's kind of like balancing the risk of side effects with
Like what?
the
What kind of
efficacy.
side effect? What
So, like, thinking about, like, opioids or benzos, which can also, like, suppress symptoms, but come with a whole host of side effects and are just kind of, a shotgun blanket approach to suppressing the symptoms. I like to kind of try to target whatever the symptoms are. So, if somebody is, like, posturing a lot, then maybe baclofen I would reach for. But really, I try to stick with, like, propranolol and bromocriptine as the initial medication.
My approach is they're on drips. I come in the morning, they're on way more infusions, usually fentanyl and dexmedetomidine combinations. And
Mhm.
they're really just flat out, they look like they're dead, they don't move, and they're
Yeah.
stark controlled, and you do the wake ups, which you're supposed to do.
Yeah.
It terrifies the nurses.
Yeah.
And I keep saying to them, I gotta see it. We
Yeah.
have to see it. Oh no, and whatever. And there are some ICUs, trauma ICUs, where they'll just keep you sedated for a week, no wake up. So I think that's less and less these days. But
Yeah.
I remember seeing people with like decubitus ulcers in the back of their head.
Yeah.
Then I do what you do, deploy, and I basically try to calm down the wake ups, right?
Uh-huh.
And I use what you're talking about, the bromocriptine, but I love fentanyl patches.
Oh,
I love
wow.
quantity patches,
Yeah. Okay.
and you just kind of load them up, slap them on, load them up with that.
Mhm.
Yeah, and then
They're still on. You got to tell the next team they're still on.
Yeah, 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 yeah. Yeah.
so they know.
Yeah. But I gotta tell you what I would like to do though, which is goes back to my research. I think there could be a role for VNS in these patients and like non-invasive VNS. And the other part of my research is doing kind of neuroimaging on this. And I think the kind of afferents that the vagus nerve targets are could potentially lead to kind of good neuromodulation on the brain to be able to help suppress a lot of these symptoms. Obviously, parasympathetic balance against sympathetic hyperactivity, it just makes sense, right? But
Yeah.
now that we have non-invasive devices, I think we need to try it.
Yeah.
Is there a scoring system that you use when you want to help, you know, escalate therapy, categorize the symptoms that the nurse can maybe do every.
Yeah, yeah. So that's the PSHAM score is really the thing that's out there, but that's composed of these two subscores, the CFS, which is the clinical feature scale, and the DLT or the diagnostic likelihood tool. And the way that I see it, we're actually we have like a EHR integration of that scoring system right now, but what we're trying to do is to make a nursing flow sheet where they can score the clinical features at least, and then potentially link that to like a PRN morphine, because right now it's also hard to know like how do you like sometimes we'll have a PRN morphine in, but you have to kind of be clear about like what you're giving it for. And but so yeah, I think the way that I would envision it is that the clinical team like decides like rules in PSH or not. And if you say yes, this patient has storming, then you kind of order the scoring system by the nurse, which is so this clinical feature scale gives you like 0 to 3 points for heart rate, blood pressure, respiratory rate, posturing, and sweating during episodes. And so that would be something that potentially the nurse could score. Maybe we would add something else like how often are they happening? And then I think the other important thing is like what are the consequences of the symptoms? Like if it's like 3 weeks into brain injury, you don't really think they're at so high risk for secondary injury at this point, and They're not like desatting with the episodes. It's just maybe a little uncomfortable to watch. You can tolerate a little bit more versus if you're trying to vent wean someone and they become hypoxic every time they're tachypnic, you might want to be a little bit more aggressive.
Mm.
That makes sense. Putting the consequences definitely.
Yeah, I don't know. What do you guys do anything with having nurses score this, or is it just
Not really.
Yeah.
But
No, that's why we need you.
Yeah, I don't know. I mean, I think our neurotrauma nurses, like they are really good at recognizing it now and have even started trying to document the score themselves. But there definitely needs to be kind of some overall clinical oversight. Like I think the big important thing is like, is this patient even somebody who we would think would have storming? Like you're not going to want to start treating storming in someone with like no brain injury. And so I think you just have to be careful with that.
Yeah. Well, I think our time's up, John. What do you think?
I think so. I think we covered a lot of great information, learned a lot. I hope the audience learned a lot as well.
Yeah. Very cool. Great to see you again, Jamie.
Nice seeing you guys too.
Yeah.
Thank you guys so much. Oh, and I also I have to give a shout out to also the physiologic data group that I've been working with at UMBC. They've been like really critical. Dr. Karen Chen is the PhD that I've been working with, and she's been really critical in helping us to like figure out how we can quantify PSH and using like episode detection modeling and things like that. So that's what we have on the horizon, and I'm thankful for her and for all the smart people I get to work with on this.
All right. Okay, that's the MASTERCLASS NCS podcast. Our guest, Jamie Odell. Everyone, thanks for listening.
Thank you. Thanks so much for having me.